Welcome back to the Deep Dive. Today, we're taking on a topic that's incredibly important and affects millions of lives. We're diving into bipolar disorders.
That's right, formerly known for many years, actually, as manic depression.
Exactly. And it's this complex chronic illness. We're talking dramatic shifts in mood, energy, activity level.
Right, cycling between these really intense highs and profound lows.
And our insights today come from a really thorough look at the subject, including this specific anthology, Whispers of the Heart, which gives such a detailed view of the human side of it.
It does, it's quite powerful.
So our mission here is to really unpack the key info,
Mm-hmm.
what these disorders are, how they show up, who's affected, and crucially, how they're treated and managed. We want to help you, our listener, get informed quickly.
Get a clear picture of what is, a really challenging illness.
Definitely. And we'll touch on some maybe surprising things.
Oh, yeah, like how long it often takes to get diagnosed. It's significant. Yeah, and the differences between bipolar I and II, they're crucial but sometimes missed. And also how things like, sleep play such a critical role in managing the condition.
Okay, let's start unpacking. At its core, what defines bipolar disorder?
Fundamentally, it's about these unusual, often really disruptive shifts, mood, energy, activity levels. They're not just minor swings.
Not just a bad day or a good day.
Not at all. These are distinct episodes. You have elevated moods, mania or hypomania, and then you have the depressed moods. And it's chronic, it's recurrent, needs ongoing, often lifelong management.
And you mentioned that diagnostic delay. How long are we talking?
It's quite startling, actually. The sources say, on average, people can suffer for about 6 years before getting a correct diagnosis and starting treatment.
6 years. Wow. That's
Yeah.
a long time to be struggling without answers.
It really is. It underscores how hard it can be to recognize, for the person experiencing it, and sometimes even for clinicians.
So how does the main diagnostic manual, the DSM-5, categorize these disorders? Where do they sit?
Well, it's positioned quite intentionally. It sits between the schizophrenia spectrum disorders and the depressive disorders.
Okay, so kind of bridging them.
In a way, the placement reflects that there are overlaps in symptoms, maybe some shared biology with both. But bipolar disorders are definitely considered distinct. They have their own unique features.
Got it. So our sources talk about three main types: bipolar I, bipolar II, and cyclothymic disorder. Can you walk us through those?
Sure. So, bipolar I disorder, this is often seen as the most severe form. You see these dramatic shifts in mood, energy, function. People cycle between, periods of relatively normal function and periods of illness.
Okay.
But a key point is, even when they're not acutely ill, many people with bipolar I have ongoing chronic difficulties. The defining feature, the absolute must-have for a bipolar I diagnosis, is experiencing at least one full manic episode.
Okay, so that history of full-blown mania is the line for bipolar I. What about bipolar II then?
Right. Bipolar II is different. It's characterized by having at least one hypomanic episode. Think of hypomania as an elevated mood state, definitely noticeable, but less severe than full mania.
Less severe.
Yes. And crucially, someone with bipolar II also needs to have at least one major depressive episode. The key distinction: they've never experienced a full manic episode.
Ah, so never the full mania. And this is where that diagnostic delay often happens.
Exactly. Because hypomania, it might not feel bad. It can even feel productive or good initially. So the person might only seek help when they're deep in a depressive episode.
Leading to maybe a misdiagnosis of just major depression.
Precisely. It happens a lot. But, and this is important, just because bipolar II doesn't have full mania doesn't mean it's less serious.
Right.
While hypermania itself is less impairing, the depressive episodes in bipolar II can be incredibly severe, very profound, and they carry a really high risk of suicide.
Okay, so bipolar I needs mania. Bipolar II needs hypomania and depression, no full mania. What about the third one? Cyclothymic disorder.
Cyclothemia or a cyclothymic disorder is more of a chronic, fluctuating thing. It involves alternating periods of hypomanic symptoms, so maybe not meeting the full criteria for a hypomanic episode, and periods of mild to moderate depressive symptoms, again, not quite meeting criteria for a full major depressive episode.
So highs and lows, but not reaching the full intensity of mania or major depression.
Exactly. And for this diagnosis, these fluctuations have to be pretty consistent. They need to persist for at least 2 years in adults.
2 years.
Yes, or 1 year in children and adolescents. And it's not always stable. There's a notable risk. The sources suggest somewhere between 15% and 50% that cyclothymia can eventually develop into full bipolar I or bipolar II.
Which again points to that idea of a spectrum, doesn't it?
It really does. And, the material also briefly touches on other types, those caused by substance use or medications or another underlying medical condition.
Right. Always important to rule out those other potential causes for mood changes. Let's really dig into the highs now, especially that full manic episode defining bipolar I. What does it actually feel like? How does it present?
Okay, so the sources describe it as a distinct period of really intense mood disturbance. You've got this persistently elevated or expansive or sometimes irritable mood.
Pensive meaning.
Like overly grand, feeling limitless. And this is coupled with abnormally increased goal-directed activity or energy, just way more than usual.
And severe.
Oh, definitely. Severe enough that it lasts at least a week, most of the day, nearly every day. Or any duration if it leads to hospitalization.
Yeah.
Because it's so disruptive, potentially dangerous, it's often considered a psychiatric emergency.
Intense is the word. What's that initial phase often like for the person?
Initially, it can feel, amazing, euphoric, incredibly energized, optimistic. People might feel powerful, like they can do anything. They often need very little sleep, maybe just a few hours, or sometimes none at all for days, and they're just in constant motion.
Like they're unstoppable.
Exactly. There's a patient quote in the material describing feeling high as a kite, thoughts clear and fast, not shy, supercharged, believing they can do anything.
That sounds incredibly potent, but maybe risky too.
Hugely risky. And often the person doesn't fully grasp the risks because of something called anosognosia.
Anosognosia.
Yeah, it's an inability to recognize you're ill, a lack of insight that's part of the illness itself, especially during mania. So they might take horrific chances, engage in really hazardous activities without seeing the danger.
And does that initial euphoria last?
Often, no. As the episode progresses, that feeling can shift, sometimes quite abruptly. It might give way to more agitation, irritability. Things start to feel less good and more fraught.
And can it escalate even further?
Yes. In more severe mania, people can experience psychosis.
Psychosis, like losing touch with reality.
Exactly. This can include hallucinations, often hearing things that aren't there, and delusions, which are these fixed false beliefs.
What kind of delusions?
Commonly grandiose delusions, believing they have special powers, immense wealth, a connection to famous people. Or sometimes persecutory delusions, feeling like others are plotting against them, spying on them. Their thinking becomes very disturbed too, marked distractibility, trouble concentrating.
What happens after this peak intensity? Does it just stop?
Well, eventually, the body just can't sustain that level of activity and lack of sleep. Sheer exhaustion often leads to a collapse, frequently crashing into a profound depression.
Wow, from that extreme high to an extreme low.
And that transition period, or sometimes a state where manic and depressive symptoms mix, is incredibly dangerous. The residual agitation or impulsivity from mania combined with the hopelessness of depression. It creates a high risk for extreme behaviors, including violence or, tragically, suicide attempts.
That transition sounds terrifying. The patient quote you mentioned earlier described it as a painful transition from feeling clear to thoughts racing uncontrollably, becoming irritable, realizing others are scared.
Yes, and the potential humiliation afterward, having to repair the damage done during the episode. It's devastating.
So, when clinicians are diagnosing a manic episode, what specific symptoms are they looking for, according to the criteria?
Okay, so beyond that core change in mood and energy, they look for at least 3 specific symptoms, or 4 if the mood is only irritable, that are present to a significant degree during that period.
Can you run through that list for us?
Sure, so number 1, grandiosity or inflated self-esteem.
Okay.
2, decreased need for sleep, feeling rested after just, say, 3 hours. 3, being more talkative than usual or having that pressured speech we'll talk more about. 4, flight of ideas or the subjective feeling that thoughts are racing. 5, distractibility, attention just gets pulled easily to anything irrelevant.
Hard to focus.
Very. 6, an increase in goal-directed activity could be work, social, sexual, or psychomotor agitation, that physical restlessness. And 7, excessive involvement in activities that have a high potential for painful consequences.
Like what kind of activities?
Things like unrestrained buying sprees, sexual indiscretions, foolish business investments. acting impulsively without regard for the fallout.
That list really paints a picture of both the internal state and the potential external chaos.
Yeah.
You mentioned pressured speech and flight of ideas. Can you describe those patterns a bit more?
Yeah, the material gives some good descriptions. Pressured speech. It's fast, it's rapid, almost frenetic. There's this inappropriate sense of urgency, like the words are being forced out. The analogy used is like a fire hose.
A fire hose.
Wow. Yeah, it's often loud, tends to be nonstop, and the person resists interruption. They just have to get it all out.
So not just talking fast, but an unstoppable quality.
Exactly. Then there are loose associations. This is where the logical connections between thoughts become, well, loose, hard to follow. The example was, the sky's the limit, drinking beer is a belly full of bags. You can maybe see a faint thread, but it jumps around.
Okay, I see. And flight of ideas.
This is a continuous, accelerated flow of speech with abrupt changes in topic. The shifts are often based on understandable associations or maybe puns or just distractions in the environment.
Like the example, home sweet home, heart of the matter, ain't hey doc.
Precisely. You can kind of follow the links, but it's jumping rapidly. In severe mania, this can become so disorganized, it's just incoherent.
You can almost hear the frantic energy in that. What about the actual content of their thoughts and speech during mania?
It can vary a lot. Sometimes it can become quite sexually explicit or vulgar. The content often reflects those grandiose ideas we talked about, believing they have extraordinary abilities or importance. And delusions are common. Those fixed false beliefs, often grandiose or persecutory. Sometimes altered sensory perceptions or even hallucinations can occur too.
So the mind isn't just racing, it can feel fundamentally altered, detached from shared reality. Does this intense state leave a lasting mark on cognitive function?
This is a really critical point that came up in the source material. Yes, it often does. While there's that interesting, maybe counterintuitive finding about higher childhood IQ sometimes being linked to later bipolar disorder.
Right. The creativity link, perhaps?
Perhaps. But the illness itself, particularly repeated manic episodes, can lead to significant and persistent cognitive problems, even when someone is in remission, eugenically stable.
Even when stable. What kind of problems?
Things like difficulties with memory, attention, executive function planning, decision-making. These deficits are somewhat similar to those seen in schizophrenia, though typically milder.
And these problems are linked to the illness course.
Yes, they correlate with things like the number of manic episodes someone's had, a history of psychosis, the chronicity of the illness, and overall poorer long-term outcomes. It really underlines why early diagnosis and treatment aimed at preventing episodes are so vital, not just for mood, but to potentially protect cognitive function.
That's huge. It means treatment choices should maybe consider cognitive impact too.
Absolutely. It's another layer to consider when selecting medications and therapies.
Okay, we've focused a lot on the manic highs. Let's talk about the other pole, the depressive lows.
Right. The depressive episodes in bipolar disorder share the same core symptoms as major depressive disorder, that persistent sadness or low mood, loss of interest or pleasure, changes in sleep and appetite, fatigue, difficulty concentrating, feelings of worthlessness.
But are they different in bipolar disorder?
The sources suggest they are often experienced with greater intensity, more profound lows, potentially, and critically, they carry the same, if not higher risks.
And this brings us to a really serious risk factor.
Yes, tragically, the risk of suicide is significantly elevated. The figures mentioned are stark. Suicide accounts for maybe 5% of deaths in women, 10% in men with bipolar disorder. Compare that to about 1% and 2% in the general population.
That's a massive difference. Are there factors that increase that risk further?
Yes, things like having an early onset of the illness, a family history of suicide, and a very strong predictor, unfortunately, is having made previous suicide attempts.
That's chilling. There was a study mentioned about symptom changes before an attempt.
Yes. Really interesting and important clinical insight. This study tracked people and found that suicidal thoughts and depressive symptoms tended to worsen significantly in the 120 days leading up to an attempt.
A 4-month window of escalating risk.
Exactly. But interestingly, the study also found those symptoms often improved in the 90 days after an attempt.
What does that tell us?
It highlights the critical need for vigilance and support during those periods of escalating distress, but also the period immediately following an attempt is still incredibly vulnerable, even if some symptoms seem temporarily better. Consistent monitoring and care are crucial throughout.
That's vital information for clinicians and families. The sources also discuss something called rapid cycling. What's that?
Rapid cycling is a specific pattern. It's defined as experiencing at least 4 distinct mood episodes. These can be depressive, manic, or hypomanic within a single 12-month period.
4 or more episodes in a year. That sounds exhausting.
It's incredibly destabilizing, and these cycles can occur quite quickly, switching over months, weeks, sometimes even within a 24-hour period in some cases.
And does rapid cycling make things more difficult?
Yes, it's generally associated with more severe overall symptoms, a higher risk of recurrence, and it can make the condition more resistant to conventional treatments. It's a challenging pattern to manage.
Okay. The material also listed conditions that often occur alongside bipolar disorder comorbidities.
Yes, comorbid conditions are extremely common and can significantly complicate the picture. Substance use disorders are a big one.
How common?
Very, affecting over half of people with bipolar cyst and maybe around 37% with bipolar II. There's often speculation that this might start as a way to self-medicate the mood symptoms.
That probably makes things worse.
Almost always, yes. It tends to worsen the course of the illness. And alcohol misuse specifically is strongly linked to an increased risk of suicide in this population.
What other conditions often co-occur?
Anxiety disorders are very frequent, seen in about 3/4 of people with bipolar II. Eating disorders, especially binge eating disorder, are also notably present, maybe around 14% in bipolar II. ADHD is common, particularly in children who might have cyclothymia, and it can complicate managing bipolar I. And the sources also mention things like disruptive, impulse control, or conduct disorders.
And it's not just other mental health conditions, right?
Yeah.
Physical health, too.
Absolutely. People with bipolar disorder have higher rates of serious medical conditions. Migraines are common, and a big concern is metabolic syndrome.
Metabolic syndrome. That's a cluster of issues.
Right. It includes things like high blood pressure, high blood sugar, unhealthy cholesterol levels, excess fat around the waist. And having this cluster significantly boosts the risk for heart disease, stroke, diabetes, and ultimately premature death.
So managing physical health is just as crucial.
It's essential. It has to be part of the overall treatment plan.
Okay, so it's a complex illness with many facets. Let's shift to who is at risk. What are the main contributing factors?
Biological factors play a really strong role. Genetics are huge.
How strong?
Well, while the lifetime prevalence in the general population is around 4%, if you have a close family member with bipolar disorder, your risk is significantly higher. And in identical twins, if one twin has it, the concordance rate, the chance the other twin also has it, is around 60%. That points to a powerful genetic component.
That's very high. The sources mention an interesting, maybe controversial link with intelligence or creativity.
Yes, it's something that comes up in the research. Some studies suggest a possible association between, say, higher childhood IQs, especially verbal, and later development of bipolar disorder. Also, potentially higher educational and occupational status compared to those with unipolar depression.
And more common in creative fields.
There seems to be a higher proportion among creative writers, artists, highly skilled professionals. It's a complex link, maybe related to certain thinking styles, but it's definitely noted in the literature. Still being explored, you know.
Fascinating. Are there genetic links to other conditions too?
Yes, research is finding connections. One large study found bipolar asthma seems to share quite a bit of genetic overlap with schizophrenia, especially regarding psychotic features.
Okay.
Whereas bipolar II seems genetically more correlated with major depressive disorder, and there's also some shared genetic ground found with autism spectrum disorder.
So the genetics are complex and paint a picture of shared vulnerabilities across different diagnoses. What about the brain itself? Any specific areas involved?
Definitely. Neurobiological studies point towards dysfunction in key brain regions that regulate mood, behavior, and thinking. We're talking about the prefrontal cortex.
Which handles executive functions, right?
Yeah.
Decision-making, planning.
Exactly. Also the hippocampus, crucial for memory formation, and the amygdala, which is central to processing emotions and decision-making. Dysfunction in these interconnected areas is thought to underlie things like the emotional ability, the heightened sensitivity to rewards you see in mania, and general emotional dysregulation. Some studies also suggest potential loss of gray matter in these regions over time.
And hormonal systems, is there a connection there?
Yes, the neuroendocrine system is involved. Research has focused on the HPTA axis, the hypothalamic pituitary adrenal axis, which regulates our stress response. It often seems dysregulated in bipolar disorder.
Okay.
And interestingly, on a related note, hypothyroidism, an underactive thyroid gland, is a common physical issue found in people with bipolar disorder. It's something that needs to be screened for, as it can sometimes go undetected and worsen mood symptoms.
And what about inflammation after that link to mood disorders?
Yes, that's another key biological factor. Levels of peripheral inflammation markers in the bloodstream are often found to be increased during both manic and depressive episodes.
And they go down between episodes?
Generally, yes. They decrease during periods of remission. This finding seems consistent with the changes in the HPTA axis, and this inflammation is also thought to contribute to some of the cognitive difficulties people experience.
So a really complex interplay of genes, brain structure and function, hormones, inflammation. What about environmental factors? Do they play a role?
They absolutely do. While they don't typically cause the disorder on their own, they can significantly influence its course and severity, especially in someone who already has that biological vulnerability.
Like what kind of environmental factors?
Well, growing up in a stressful family environment or experiencing major adverse life events can lead to a more severe illness course. And for adults, relationship stress, work stress, financial stress is a very common trigger for episodes, both manic and depressive.
And childhood experiences seem particularly important.
Extremely important. The research highlights a strong link between childhood adversity, things like physical, sexual, or emotional abuse, and also emotional neglect, and the later development of bipolar disorder.
Any specific type of adversity standing out?
Emotional abuse in particular was associated with something like a 4 times higher likelihood of developing the disorder. And experiencing this kind of early trauma isn't just linked to developing the illness, it's also linked to worse outcomes later on.
Worse outcomes how?
More frequent and severe episodes, an earlier age of onset, higher suicide risk, more problems with substance misuse. It really does cast a long shadow and complicates the illness significantly.
That really emphasizes the need for trauma-informed care. Is there a specific environmental trigger mentioned for women?
Yes, a critical one is severe postpartum psychosis, occurring shortly after childbirth, usually within the first 2 weeks.
Postpartum psychosis.
Women who experience this have a significantly higher chance, the source mentioned 4 times greater, of eventually being diagnosed with bipolar disorder. It seems linked to the dramatic hormonal shifts and, critically, the severe sleep deprivation that often happens after birth.
And sleep deprivation is a trigger even outside of postpartum.
Absolutely. Lack of sleep is a well-known trigger for mania and psychosis in women and men who already have bipolar disorder. It's a crucial factor to manage.
That's vital for postpartum care, but also ongoing management. The material also touched on a somewhat controversial history regarding diagnosing bipolar disorder in children.
Yes, that was a significant issue, particularly back in the early 2000s. There was a sharp increase in diagnosing young children with bipolar disorder, often based mainly on symptoms like chronic irritability and severe temper outbursts, rather than distinct mood episodes.
And the concern was?
The concern was that this diagnosis often didn't persist into adulthood. Many of those children were later diagnosed with something else, like major depressive disorder or anxiety disorders. But in the meantime, they'd received this lifelong, highly stigmatizing label and been exposed to powerful mood-stabilizing medications during critical developmental years.
So how did the field address that?
Well, in 2013, the DSM-5 introduced a new diagnosis called disruptive mood dysregulation disorder, or DMDD.
DMDD.
Right. It was specifically designed to better capture that pattern of persistent irritability and severe outbursts in children, partly to try and reduce the overdiagnosis of pediatric bipolar disorder based on those symptoms alone.
But bipolar disorder can still emerge in adolescence.
Oh, absolutely. It often does emerge during late adolescence or early adulthood, and when it does appear that early, it's a serious concern, with prevalence rates similar to adults and, sadly, a strong association with suicide attempts in that age group.
So careful diagnosis across the lifespan is key. Okay, let's pivot to assessment and care, especially when someone is in that acute manic phase. What's the priority?
Priority number 1 is safety. Always, you have to assess, is this person a danger to themselves or others? During mania, the lack of sleep, the poor impulse control, the impaired judgment, it creates a high-risk situation.
And they often need protection from their own impulsive actions, you mentioned.
Definitely. Because of that poor judgment, they might do things with serious consequences, like spending all their money, making reckless decisions, engaging in risky behaviors. So assessing the need for external structure and protection, often meaning hospitalization, is crucial to prevent harm, like financial ruin or damaged relationships.
And you also need to rule out other causes for the symptoms.
Absolutely. A thorough medical workup is essential. Are the manic symptoms actually due to substance use, a side effect of a medication, or another underlying medical condition like a thyroid problem or neurological issue? You have to rule those out.
Makes sense. What else is part of that initial assessment?
Assessing the patient's and their family's understanding of the illness is vital. Do they know what bipolar disorder is? Do they understand the proposed treatment, the medications? What support systems do they have in place? This information is key for planning ongoing care.
Based on this assessment, what are the main goals of care, especially during that acute manic phase in the hospital?
Okay, so the goals really align with the phase of the illness. In that acute phase, when the manic or hypomanic episode is actively happening, the immediate goals are symptom reduction, getting the mania under control and achieving remission. Alongside that is injury prevention, ensuring their safety, and restoring physiological stability.
Physiological stability, meaning
Making sure they're eating, drinking, sleeping, basic physical needs that often get completely neglected during mania. Hospitalization is usually required to achieve these goals safely.
and once the acute phase is managed, what's the next phase?
That's the maintenance phase. The primary goal here shifts to preventing relapse, stopping future episodes from happening, or at least limiting their severity and duration if they do occur.
And that involves long-term treatment.
Yes, usually lifelong medication adherence is necessary. But recovery in this phase isn't just about taking pills, it's also about helping the person rebuild and recover from the impact of the acute episode.
Rebuilding how?
Addressing the interpersonal fallout, damaged relationships, dealing with occupational or educational setbacks, sorting out financial messes, helping them reestablish a stable, functional life. Support systems, family, therapy, support groups are absolutely critical during this phase to help repair lives that can feel shattered by the behavior during episodes.
Given how intense acute mania can be, what are some practical strategies used by staff in a hospital setting to manage it?
Safety and providing external structure are paramount. Staff need to set clear limits on behavior, but do it firmly, calmly, non-threateningly, and neutrally. Avoid power struggles, which can just escalate things.
Communication must be tricky with the pressured speech and distractibility.
It really can be. The key is to use a firm, calm approach. Keep statements short and concise. Be very consistent. Everyone on the team needs to be on the same page to avoid manipulation or splitting.
Splitting.
Yeah, where the patient might pit staff members against each other. So, consistency is vital. Set concrete expectations with clear consequences. If you're able to stay calm, you can stay in the day room. If not, you'll need some quiet time in your room. Listen to legitimate complaints, but gently redirect their energy. That distractibility we talked about. You can sometimes use it therapeutically to shift their focus away from agitation or problematic behavior.
What about managing those basic physical needs? Sleep, food, hydration.
Absolutely essential. They're often too agitated or distracted to sit for meals, so offering frequent high-calorie fluids and finger foods they can eat on the go is key. You have to monitor their intake, output, and vital signs very closely to prevent dehydration and exhaustion.
And sleep.
Encourage frequent rest periods during the day. Create a low-stimulus environment, especially at night. Dim lights, reduced noise. Things like warm baths or quiet music might help promote relaxation. And definitely avoid caffeine or other stimulants.
What about basic self-care, like hygiene?
They may need help with that too. Encourage appropriate clothing choices. Provide simple step-by-step reminders for hygiene tasks like brushing teeth or showering, and monitor elimination, offer high-fiber foods and fluids, and assess if a laxative might be needed due to potential dehydration or medication side effects.
That case study of Jasmine in the material really brought this to life, showing the nursing care plan focused on tracking her fluids, her sleep, her vitals during acute mania.
Exactly. It illustrates that fundamental, hands-on care needed to stabilize someone physically and behaviorally. The sources also rightly emphasize the need for frequent staff meetings.
Why is that important?
To maintain that consistent approach, to strategize around particularly challenging behaviors, and also for staff support. Working with acute mania can be very demanding and emotionally taxing, so debriefing and planning together helps prevent burnout and staff splitting.
And sometimes Despite all these efforts, more restrictive measures like seclusion or restraint might be needed.
Yes, unfortunately, sometimes they are necessary as a last resort. The criteria are very specific. Only when there's a substantial immediate risk of harm to the patient or others, the patient is totally unable to control their actions, and all other less restrictive measures have failed.
And there are strict rules around this.
Very strict. Ethical and legal protocols must be followed. This includes needing a written physician's order, which has to be reviewed and rewritten frequently, continuous observation or monitoring, regularly offering fluids, food, and bathroom breaks, checking vital signs.
And it's critical that it's never used for punishment, right?
Absolutely not. Never for punishment or just for staff convenience. Communication, even during seclusion, remains important, keeping it concrete, direct, empathetic, reassuring the patient that it's a temporary safety measure, and the goal is to help them regain control so they can return to the main unit.
Okay, that covers acute care well. Let's move into treatment modalities. The material heavily emphasizes biological treatments, starting with medications.
Yes, pharmacotherapy is really the cornerstone of treatment for bipolar disorder. The main category of drugs used are known as mood stabilizers.
Mood stabilizers. Do they stabilize both highs and lows?
Well, the name is a bit general. Not all drugs in this class are equally effective for both mania and depression. Some are better for mania, some better for depression maintenance, but generally they are the first line of defense.
And the classic historical mood stabilizer is lithium.
Yes, lithium is one of the oldest medications used, and it's FDA approved for both treating acute mania and for long-term maintenance to prevent future episodes. It generally takes a bit of time to work fully, maybe 10 to 21 days.
So often used with other meds initially.
Exactly. It's often supplemented with faster-acting medications like certain antipsychotics or benzodiazepines in the very beginning to manage acute manic symptoms while the lithium level builds up.
Patty Duke famously credited it with saving her life.
She did. A very powerful testament. It can be incredibly effective, especially for reducing symptoms like the elation, the grandiosity, flight of ideas, irritability, anxiety, even self-injurious behavior sometimes seen in mania or mixed states. It tends to be less effective, though, for things like insomnia, agitation, distractibility, or hypersexuality.
Its use is declining somewhat, you mentioned.
Yes, partly because newer medications have been developed, some with perhaps different side effect profiles or less need for intensive monitoring, but lithium remains a very important and effective option for many people.
And that monitoring aspect is crucial for lithium.
Absolutely critical. Lithium has what we call a very narrow therapeutic window. Meaning the dose that's effective is very close to the dose that can become toxic. So blood levels have to be monitored very carefully and regularly.
How often?
Initially, when starting or changing the dose, maybe every 2-3 days. Once stable, it's typically checked every 3 to 6 months during maintenance treatment. The target levels are quite specific, usually 0.8 to 1.2 millieql for acute treatment and slightly lower, maybe 0.6 to 0.8 millieql for maintenance.
And what happens if the level gets too high? What are the signs of toxicity?
It's a spectrum. Early signs of toxicity, maybe around 1.5 to 2.0 millieql, can include things like significant GI upset, nausea, vomiting, diarrhea, a coarse hand tremor, different from the fine tremor that can be a side effect at therapeutic levels, confusion, muscle hyperirritability or twitching, sedation, and incoordination.
And if it gets even higher?
Then it becomes much more serious. Levels above 2.0 or 2.5 millieql can lead to ataxia, staggering gait, giddiness, blurred vision, large outputs of dilute urine, clonic movements, jerking, seizures, stupor, severe low blood pressure, coma, and potentially death. Severe toxicity often requires emergency medical treatment, sometimes including hemodialysis to remove the lithium from the blood.
Wow. So even milder side effects need attention.
Yes, even below 1.5, people might experience nausea, vomiting, diarrhea, thirst, increased urination, lethargy, that fine hand tremor. And long-term use can potentially affect kidney and thyroid function, so those need to be monitored regularly too.
That really drives home the need for careful management and patient education. Are there people who shouldn't take lithium?
Yes, there are contraindications. It's generally avoided in people with significant cardiovascular disease, brain damage, severe kidney or thyroid disease, or a condition called myasthenia gravis. It's also generally contraindicated during pregnancy and breastfeeding, and typically not used in children under 12.
Okay. The material also discusses anticonvulsant drugs being used as mood stabilizers.
That's right. Several medications originally developed to treat epilepsy, or seizures, have been found to be very effective in treating bipolar disorder symptoms and are FDA approved for this.
Are they better for certain types of bipolar disorder?
They can be particularly useful for people who experience rapid cycling or for those who don't have a strong family history of bipolar disorder responding well to lithium. They can also be helpful in managing impulsivity or aggression, and sometimes in managing mood symptoms during substance withdrawal. Generally, they tend to control mania within about 2 weeks, but might take longer, maybe 3 weeks or more, to help with depression.
Which specific anticonvulsants are commonly used?
One major one is valproate, which includes divalproex and valproic acid. Brand names like Depakote are common. It's FDA approved for acute mania and for preventing future episodes.
Does it have significant warnings?
Yes, it does. There are black box warnings regarding potential liver toxicity, hepatotoxicity, low platelet counts, thrombocytopenia, and inflammation of the pancreas, pancreatitis. These are rare but serious. But the major black box warning relates to pregnancy.
What's the risk in pregnancy?
Valproate carries a significant risk of major birth defects, including neural tube defects like spina bifida, cleft palate, cardiovascular problems, and potentially developmental issues like lower IQ scores or autism spectrum disorder characteristics. It's considered highly teratogenic.
So what does that mean for women taking it?
It means pregnancy screening before starting is essential, and reliable contraception is absolutely mandatory for women of childbearing potential using this medication. The risks need to be discussed very clearly.
That's incredibly important. What other anticonvulsants?
Carbamazepine, particularly an extended-release form called Equetro, is FDA approved for acute mania and mixed states. It's often considered a second-line option. It has a lot of complex drug interactions because it affects liver enzymes. It's a CYP450 inducer.
So monitoring is needed.
Yes, regular monitoring of liver function and complete blood count (CBC) is needed because it carries risks of bone marrow suppression, liver inflammation, and potentially serious blood disorders like leukopenia or aplastic anemia, though these are rare.
Any other major warnings for carbamazepine?
Yes, another very important black box warning is for serious dermatologic reactions, specifically Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TNAN. These are severe, potentially fatal skin reactions.
Is the risk higher for some people?
Yes, the risk is significantly higher in individuals of Asian ancestry due to a specific genetic marker, HLA-B1502. Genetic testing is often recommended for these individuals before starting carbamazepine.
Wow, another critical safety point. What about lamotrigine?
Lamotrigine, brand name Lamictal, is different. It's primarily FDA approved for maintenance treatment of bipolar disorder in adults, 18 and older, to delay the time to mood episodes, particularly depressive ones. It's generally well tolerated compared to some others.
But it has risks too.
Yes, the main concern, again, is a rash. About 10% of people might develop a benign rash. However, there's a small risk, about 1% overall, but higher in children when used with valproate, or if the dose is increased too quickly, that this rash can progress to that same serious, life-threatening SJS.
So any rash needs immediate attention.
Absolutely. The standard instruction is to discontinue lamotrigine immediately at the first sign of any rash and seek medical evaluation, unless it's clearly known not to be drug-related.
Okay, so these mood stabilizers, while essential, come with significant potential risks needing careful management. What about the role of second-generation antipsychotics?
Yes, many of these newer antipsychotics, sometimes called atypical antipsychotics, are also FDA approved, particularly for treating acute mania. They often have mood-stabilizing properties in addition to their antipsychotic effect.
Do they work quickly?
They often work relatively quickly, and many have sedative properties which can be very helpful initially in calming agitation and improving sleep during acute mania. Examples mentioned include olanzapine, Zyprexa, risperidone, Risperdal, quetiapine, Seroquel, ziprasidone, Geodon, aripiprazole, Abilify.
And what's the main concern with these?
A major concern, emphasized in the sources, is the risk of metabolic side effects. Things like significant weight gain, increased blood sugar leading to diabetes, and unhealthy changes in cholesterol levels. So, baseline and ongoing screening for these metabolic problems is absolutely essential when using these medications.
Got it. The term off-label use also came up. What does that mean here?
That just means a doctor is prescribing a medication to treat bipolar disorder based on their clinical judgment, perhaps supported by some research, even if the drug hasn't gone through the formal FDA approval process specifically for that bipolar indication. It's a common practice in psychiatry.
Okay. Beyond conventional medications, were any integrative therapies mentioned?
Yes, the material discussed omega-3 fatty acids, the kind found in fish oil, specifically EPA and DHA.
Why the interest in those?
Well, partly it stems from epidemiological research suggesting that populations consuming less seafood seem to have higher rates of mood disorders. A specific review mentioned found that while omega-3s didn't seem helpful for treating mania, there was actually strong evidence suggesting they could be beneficial as an add-on treatment for improving depressive symptoms in bipolar disorder.
Interesting. So potentially helpful for the lows. What about brain stimulation therapies?
Yes, a couple were highlighted. The oldest and most studied is electroconvulsive therapy, ECT.
ECT. That still sounds intense to many people.
It can, but it's a highly effective and safe procedure when done properly. It involves passing a controlled electrical current through the brain to induce a brief seizure under anesthesia.
And it's used for bipolar disorder.
Yes, very much so. It's often much faster acting than medications, especially for severe depression, sometimes showing improvement within a week. It's commonly used and highly effective, around 80% effective, for severe bipolar depression, particularly in older adults who might not tolerate medications well. It's also used effectively for treating acute mania, mixed states, and sometimes even for maintenance treatment to prevent relapse.
Any impact on thinking?
While temporary confusion right after treatment can occur, one study mentioned actually showed overall improvement in cognitive function with ECT in bipolar disorder, perhaps by treating the underlying severe mood state that was impairing cognition.
Okay. What about the other one, RTMS?
Repetitive transcranial magnetic stimulation, RTMS. This is a newer, non-invasive technique. It uses magnetic pulses generated by a coil placed on the scalp to stimulate specific areas of the brain.
Is it approved for bipolar disorder?
It's FDA approved for treatment-resistant major depressive disorder, but not specifically for bipolar depression yet. However, the sources mention research supporting its potential use, particularly in older adults with bipolar depression, and also some evidence suggesting it might improve cognitive function in people with bipolar disorder. Still emerging, but promising.
So a range of biological treatments are key. But as we know, medication is rarely the whole story. What about psychological therapy?
Absolutely essential. Psychological therapies, or psychotherapies, are crucial adjuncts to medication. They don't replace the need for meds to manage the core biology, but they address so many other vital aspects.
What are the goals of therapy in bipolar disorder?
The goals are broad: helping individuals develop better coping skills, learning to identify early warning signs of relapse, reducing the risk of future episodes, working through the immense relationship work and social difficulties the illness often causes, decreasing overall psychological distress, improving self-esteem, enhancing functioning between episodes, and ultimately aiming to decrease the frequency of future episodes.
Which specific therapies are helpful?
Cognitive behavioral therapy, CBT, is widely used and well-researched. It focuses on identifying and modifying maladaptive or unhelpful patterns of thinking and behaving.
How is CBT applied to bipolar disorder specifically?
It often focuses on very practical things: strategies to improve medication adherence, skills for early detection of manic or depressive episodes, stress management techniques, lifestyle regulation like sleep patterns, and also treating any comorbid conditions like anxiety or substance use. There's research showing CBT can significantly improve medication adherence, especially with challenging regimens like lithium.
Interpersonal and social rhythm therapy was also listed.
Yes, IPSRT. This therapy specifically focuses on the link between moods, daily routines, especially sleep-wake cycles, and interpersonal relationships. The idea is that stabilizing daily rhythms and managing relationship stress can help stabilize mood and prevent episodes.
And family-focused therapy, FFT. That sounds crucial given the family impact.
Incredibly important. Bipolar episodes put enormous strain on families. FFT works with the patient and their family members to improve communication, reduce conflict and criticism, what's sometimes called negative expressed emotion, and help the family unit identify and manage stressors that might trigger episodes. Educating the family is key.
What about support groups?
They play a vital role. Peer support can be incredibly validating and helpful, both for the individuals living with bipolar disorder and for their friends and family members who are supporting them. Organizations like DBSA, Depression and Bipolar Support Alliance, NAMI, National Alliance on Mental Illness, and Mental Health America offer these groups.
And they're more accessible now.
Yes, the material noted the rise in virtual or online support groups has actually led to improved attendance for many people, making it easier to connect and get that peer support.
So it really takes a village: medication, therapy, family support, peer support. Looking long-term now into the maintenance phase, what's key for living well with bipolar disorder?
The number one focus is relapse prevention and maintaining stability. As we've said, lifelong medication adherence is usually the foundation.
And beyond medication, lifestyle.
Hugely important. Establishing and maintaining regularity in daily routines is critical. Consistent sleep patterns are paramount. Regular meal times, regular exercise, managing stress. Creating a predictable structure helps stabilize mood.
You keep coming back to sleep. It's really that central.
It absolutely is. Sleep disturbance, especially lack of sleep, is one of the most reliable early warning signs of an impending manic episode for many people. Sometimes intervening quickly right then, maybe with a short-term sleep medication, or intense focus on sleep hygiene practices can actually help avert a full-blown episode. Consistent, good quality sleep is fundamental for stability.
So health teaching for patients and families must cover all this.
Definitely. They need ongoing education about the chronic episodic nature of the illness and the need for long-term treatment. They need to know the expected side effects of their specific medications and, crucially, the signs of toxicity.
Especially with lithium, as we discussed.
Exactly. The teaching for lithium needs to cover maintaining consistent fluid and sodium intake, knowing to stop the medication and seek advice if they become dehydrated, like from vomiting, diarrhea, or excessive sweating, understanding potential interactions with diuretics, common painkillers like NSAIDs, ibuprofen, naproxen, and even some over-the-counter meds, and reinforcing the need for those regular blood tests.
What else is crucial in patient-family education?
Recognizing the signs and symptoms of relapse, those early warning signs for both mania and depression. Understanding that episodes can sometimes feel like they come out of the blue. Knowing the role family and friends can play in spotting changes and encouraging help seeking. Having emergency contact information readily available.
And avoiding triggers.
Yes, understanding the importance of avoiding alcohol, recreational drugs, excessive caffeine, especially from energy drinks, and certain over-the-counter medications that can destabilize mood and trigger a relapse.
And teaching coping strategies for life's challenges.
Essential. Strategies for managing stress from work, relationships, finances. Building a sense of control, improving community functioning. These all contribute to better long-term outcomes.
You mentioned earlier that weight gain from medications can be a big issue.
Yes, particularly with some of the second-generation antipsychotics, but also other mood stabilizers can cause it. This weight gain and the associated metabolic disturbances are a major reason why people sometimes stop taking their medication, which is obviously very risky.
So addressing that is part of the teaching.
It has to be. Providing education and support aimed at weight reduction and management, diet, exercise, lifestyle changes is a critical part of comprehensive care and supporting long-term adherence.
The material also mentioned resources like NIMH brochures.
Right, just pointing out that reliable information is available from trusted sources like the National Institute of Mental Health for both adults and specific versions for children, adolescents, and their families. Continuing education is important.
And evaluation isn't just a one-time thing at diagnosis.
Not at all. Evaluation is ongoing. Is the patient currently stable? Are their physical needs, hydration, sleep, nutrition, being met? Are they managing their behavior appropriately? Does the family understand the current situation and treatment plan? Do they know how to access resources and support? It's a continuous process of monitoring and adjusting the plan as needed.
What are the desired longer-term outcomes you're looking for?
Ultimately, consistent medication adherence, good functioning in the community, work, school, social life, stability in relationships, stability in mood, and improved coping skills to handle life's inevitable stressors.
This has been an incredibly thorough deep dive. We've journeyed from understanding the core definitions and types of bipolar disorders through the intense experiences of mania and depression, exploring the complex web of risk factors: biological, environmental, developmental.
Right, and then looking at the crucial aspects of assessment and acute care, the wide range of treatments from medications like lithium and anticonvulsants to ECT and psychotherapy.
And finally, emphasizing the vital importance of long-term management, lifestyle regularity, education, and support systems.
It really highlights that while bipolar disorder is undeniably a significant, often lifelong condition, it absolutely is manageable. With accurate diagnosis, effective individualized treatment, and strong ongoing support, people can live full and meaningful lives.
Absolutely. So what does this deep dive leave us thinking about? For you, our listener, we've seen this complex picture. An illness deeply rooted in biology, yet profoundly shaped by environment, stress, and early trauma. We see these intense highs, these manias, that aren't just fleeting moods but can alter thinking, behavior, and even cognitive function long term. And recovery is clearly a holistic journey.
It involves medication, yes, but also therapy, lifestyle adjustments, and often rebuilding parts of one's life.
So, considering that strong link between childhood adversity, especially emotional abuse, and worse outcomes later on, and then that tentative but persistent association with creativity and high achievement, what does this complex interplay suggest? How might recognizing these connections, the vulnerability from trauma alongside potential strengths, influence how we approach mental health care, how we build support systems, maybe even how we foster potential and resilience in individuals who are navigating the challenges of living with bipolar disorder? Something to think about.